have the speakers for the next session with us. On contemporary ultrasound technology transforming imaging. May I invite Dr. Rahul Sachdev, Director R Diagnostics, who's going to be moderating this session. Dr. Sachdev, you could join us on stage. Can we have a round of applause, please? Dr. Kavita Aneja, Director and Senior Consultant, Images Ultrasound Centre. Welcome, ma'am. Dr. Tandra Sarkar, Senior Consultant Radiologist, Apollo Multispeciality Hospital. Dr. Sarkar, are you here? Yeah, welcome, ma'am. And I think we will be joined by Dr. Alka A Singhal, Associate Director Radiology, Medanta Medicity. So while she's, reaching here, may I request Dr. Rahul Sachdev to start the discussions around this very interesting topic of contemporary ultrasound technology transforming imaging. Over to you, sir.
Good evening, everybody. Lovely to see the audience out here. The topic is contemporary ultrasound technology and how is it transforming the imaging. As she said, while we wait for Dr. Singhal, we can just start with Dr. Sarkar and Dr. Aneja. Dr. Sarkar, the first question to you. We have this huge discussion on artificial intelligence, which we just had for almost, I think, half an hour just before this. What do you feel is the role of ultrasound in artificial intelligence? How is it affecting us?
Very good afternoon. At this outset, I'll definitely want to thank Elets to give me the opportunity to be here. I'm really fortunate that I heard so many discussions which are non-radiological government policies, and it really enriched me. We have listened half an hour's discussion about the artificial intelligence in radiography, and my topic is that I'll be discussing how that artificial intelligence enriches ultrasound. It has, ultrasound applications of AI has come quite late after the machine learning of X-rays, mostly for the chest diagram, and then traumas, then pneumothorax, nodules, etc. And then CT applications. In COVID screening, there was extensive work on artificial intelligence. But AI in ultrasound is a little cumbersome procedure. It has come late, and now work is going on, mostly to enable ultrasound in remote, peripheral, low resource areas, with the idea that ultrasound become available, accessible to people, which will be done by persons who are less trained, almost untrained, and the images can be read. Work is going on with an AI integrations, which will be used both pregnant and non-pregnant women. For the pregnant one, PCPNDT Act is a little complications which needs to be overcome, and then that machines, how these integrations will be done, that is the machine learning will be on, machine learning is being done on pregnant and non-pregnant women, where that handheld probes will be used. It will be used by mostly non-trained people, maybe ASHA workers, or sometimes it can be remote held also. And then it will be converted from 2D to 3D image, can be transferred through PACS, and the image will be read to the tertiary care centers, where the reporting can be done. These are the lot of projects are going on, and vendors are coming on these projects. Okay.
Thank you. As you mentioned, and Dr. Jain was just telling us in the previous session, where they are doing a lot of work on the ultrasound, and with this PCPNDT issues, do you really see AI coming into obstetric imaging in a big way, where actually sonographers, so as to say, will be scanning in the periphery and the images will be transferred to a tertiary center? Do you think PCPNDT in this country will allow it, or how do you feel is the future going to be?
In India, PCPDT Acts will prevail and will remain. So machines can be mostly in a machine, some software will be there where it will be blind and amniotic fluid can be assessed, or it will be covered in some areas so that a sex cannot be exposed. These are the areas, these segmental applications in the machine will be there where the sex can be covered. In that way, the TCPNDT applications will be overcome.
Since we are on the topic of fetal imaging, Dr. Kavita has done a lot of work on fetal imaging, which she's currently doing, and there is a program by the name of Samrakshan, which the Indian Radiology Association has taken a good initiative towards it. Dr. Kavita, could you please elaborate on this program, exactly what is it? And
hello. Yeah, thanks, Dr. Rahul, for the question, and thanks indeed for having me here. So, as much as we are talking of high-end technology and contemporary ultrasound techniques, I would like to put it this way: life begins before birth, and so healthcare must begin before birth. Now, technology has brought a revolution in antenatal care. Having said that, most of our focus so far has been on congenital anomalies and aneuploidies. But to be honest, the major chunk of adverse pregnancy outcome arises from fetal growth restriction. And this goes without saying. And so this area of antenatal care needs special attention, because it is these babies which are growth restricted, which are low birth weight, which are premature, which are born to hypertensive mothers or preeclamptic mothers. These are the babies who have long-term implications on their health in adult life. So in adulthood, these are the ones who have higher incidence of cardiac disease, metabolic disorders, diabetes, obesity, hypertension, and even cerebrovascular events. And this is exactly what Samrakshan is about. So Samrakshan is an initiative by IRIA, and this was founded in 2019 by Dr. Riju Matthew under the presidentship of Dr. Hemant Patel. And this actually addresses the issue of perinatal mortality, neonatal mortality, and maternal mortality in India, besides FGR and preeclampsia. So why are we talking about these mortality rates so much? Because India is the world capital of stillbirth. India contributes to 25% of world statistics as far as perinatal mortality and maternal mortality is concerned. And so these figures are really alarming, and we need to do something about this. Samrakshan urges all radiologists to use technology, which is color Doppler, in antenatal care to address this issue of perinatal mortality, neonatal mortality, and maternal mortality besides FGR and preeclampsia. This issue is plaguing our country. It's high time we rise. That's what Samrakshan is about.
thanks. Now, since you're talking of ultrasound technology and transforming the imaging scenario, both of us have been doing ultrasound for so many years, and we've been into fetal imaging. And about 30 years ago is when color Doppler imaging came into being, actively into practice. And prior to that, we were looking at biophysical profiles, and we were scoring the fetuses, and our usual 8 on 8, 10 on 10s, and 5 on 10s. We still do receive, surprisingly, we still do receive prescriptions in which it is mentioned very categorically that they want the biophysical score. So my point is, from the biophysical score to the Doppler, where exactly do you feel the biophysical score stands, and what do you feel the color Doppler has revolutionized, or exactly what has it done to that?
So here I'd like to mention that again, Samrakshan, it has it focuses on two areas. The first is in the first trimester, use of technology, that is ultrasound, color Doppler ultrasound, to predict fetal growth restriction and preeclampsia. So this prediction is done, I'll come to this later on, how do we do it? And according to the risk the patient comes in, if it is a high risk, which is more than 1 in 150, these patients will be put on tablet ecosprin 150 milligram HS till 36 weeks or delivery, whichever is earlier. So this is the first focus of Samrakshan, which is preeclampsia and FGR screening in the first trimester with the help of technology. The second focus is what Dr. Rahul is commenting on, that is the use of color Doppler in the third trimester. So Samrakshan categorically emphasizes the role of color Doppler in each and every scan in the third trimester. So no scan in the third trimester is without a color Doppler. The doctor may advise or not, the patient may pay or not, you have time or not. It has to be a color Doppler. And why so? Because now we know we have fetal growth restricted babies under AGA category. AGA means appropriate for gestational age. So these babies, if we only go by biometry, these babies will fall in normal age category. So normal weight. So the weight will be above the 10th centile, and you will not call them FGR, but this is FGR in AGA, which can only be detected if we do color Doppler and see the Dopplers are abnormal. Even if the weight is more than 10th centile, it is an FGR baby. And most of the late onset FGRs will fall into this category. And these are the ones which have sudden deaths, where it is unexplained adverse pregnancy outcome we come across. It is because we are not doing Dopplers. So every third trimester scan, please do a Doppler. We need to diagnose FGR early, we need to diagnose preeclampsia early, we need to stage FGR, and stage-based management protocol is what we need to follow. And this is by Greatocos, Barcelona, Greatocos that we are following in Samrakshan. And that is how we can improve our low birth weights, premature babies. How will we know what is the right time of delivery if we are not doing color Dopplers? So we don't want to wait too long for acidemia or hypoxia to set in. We don't want to deliver these babies too young for the fear of prematurity. So to know the right time of delivery, and we just don't need a live baby, we need a neurologically healthy baby. And for this, color Doppler is an absolute must. There is no ultrasound like biophysical score without color Doppler in third trimester.
You know, this might sound not cutting edge like artificial intelligence, but color Doppler has been around for 30 years, and we are still doing WHO funded projects without Doppler. We are still doing them. The emphasis is just not there on how important. The reason why I asked about the biophysical profile was because we need to understand that you need to do your Dopplers right from the first trimester. The uterine artery notchings, they have a meaning. They have a clear forbearance to preeclampsia. There are so many things that treatment, like she was talking about, the Loprins or the low dose aspirins, they can be started early. So these are things which we must understand and emphasize, that Doppler till today, even after 30 years, is not really incorporated into fetal imaging the way it should be. All right, coming to you, Dr. Sarkar, you know, one of the few things which has caught our fancy in the last decade or so is elastography. And the whole essence I would say, was to see a lesion, and when you saw lesion, you wanted to know whether it was hard or was it soft, with the understanding that a hard lesion would more or less be more in favor of a malignant lesion. And as radiologists, we really come into the domain where the lesions are not palpable. Because as far as the palpable lesions are concerned, the clinicians really don't need us. But whenever we're looking at deep-seated lesions and we want to know whether it is hard or soft, that is where the elastography came in. And from then the elastography moved on to focal and diffuse lesions, where we started talking of the focal lesions also to see, like in the liver, like in the breast. So what is your experience with elastography, and how do you think it has progressed over the last decade or so?
Elastography. Hello. So elastography is a elastography has come maybe 20 years down the line. It has come in initial form as the there are two types, shear wave, and the other one is the strain and shear, of course. The strain wave, initially it has come as a strain wave and then to shear wave. What is elastography is to know about the elasticity of a lesion. When it's kind of a palpation. When you can palpate, you can say this is the firm, this is soft, this is hard. The same way, the sound palpates. Sound compresses the lesion and it sees how it is moving. It is moving and it is distorting and coming to the normal area, or it is again distorted, becoming distorted. In that way, it actually measures whether this is a soft lesion, this is a firm lesion, this is a hard lesion. That is where the concept of elastography has come. So elastography, at this point, elastography is so much so in use that in Asian Birad's 5th edition atlas, elastography for breast has been made as one adjunct method, and maybe in the next edition it is coming compulsory for breast ultrasound, because in my day-to-day practice I found even a cyst with internal echoes, whether this is a soft lesion, this is a solid lesion like fibroid, or this is a lesion like cyst, with a 2D mode, even with color. Color has no role basically when it is a cystic lesion. So it is difficult to differentiate. But if one just makes the elasto on, they can understand this is a lesion like a fibroadenoma or a lesion like cyst. And then the diagnostic dilemma goes immediately. And mostly it's application on the cancer, because for the breast, initially I'm coming to the breast and then to liver. Breast, our main aim is that we should not miss any cancer. And when we are doing ultrasound, it is quite difficult to understand this is a firm lesion, this is a hard lesion. We give attention to the size, to shape, to that echogenicity, but still it is sometimes difficult to understand. And then whether this is a taller to wider, these are the common criteria to differentiate between the malignant lesion and benign lesions. And then comes the elastography, where initially strain, but now that the other elastography has been used to tell whether this is a malignant lesion or benign lesion. Color coding has been seen initially, and now since we can measure the values of RP, we can actually tell the and it is found that almost 80 to 9% cases, it is sensitive to understand that this is a benign or a malignant lesion when elastography is on.
All right, Dr. Sarkar, we were discussing elastography at that point. And you were also discussing how, mainly in the breast, how it is being used for breast cancers. And my query was that how often do you see that elastography would change your BIRADS categorization, or if you feel, let me put it this way, if you feel that a lesion is malignant on B mode, and you would change your opinion after the elastography.
So that's why I was discussing. Elastography is one such important modality that may even downstage or upgrade the BIRADS category. With elastography, the hardness is very sensitive and specific as well, to that point up to 89 to 95% sensitive and specific regarding confirmation about the malignancy, which of course gets biopsied for confirmation, but we have found that the sensitivity is very, very high on elastography. And so the B-mode ultrasound, when added with elastography, can downgrade or upgrade by grade to 4 or 5, or maybe 3, of course.
And what is your opinion about elastography used in diffuse liver disease, especially for fibrosis and cirrhosis and stuff like this?
It is nowadays being widely used, elastography, with quantitative assessment with RFI scoring, that fibrosis can be graded with whether that liver, which B mode we say that ecogenic liver, that can be graded with elastography. So this is only fatty liver, or that can different kinds of fibrosis to cirrhosis that can be confirmed with Fibroscan and elastography.
Right, yeah, please, ma'am.
Liver elastography is a great tool. It's a very nice tool because it actually allows you to feel the liver from inside without actually having to touch it. It's like almost close to biopsy. Like you can get the coarseness, you can get the quantification, and we at Medanta, we routinely use liver elastography in detecting early cases of chronic liver disease and portal hypertension. It's really contributing to early diagnosis and management, and more of it has got to be widely available, and awareness and application both will definitely contribute to the greater health of all. Thank you.
Right, wonderful. A very controversial point out here would be, at least we see a lot of gastroenterologists who are still happier with a machine which is called as Fibroscan, which is made by EcoSense, and essentially that uses transient elastography, and what we use is shear wave elastography. What is your stand on that? What is your opinion? What is the comparative data, or what do you feel about that?
Technology is advancing, so we began with that EcoSense, but that's a blinded procedure, and ultrasound ours is a targeted procedure. We can really pinpoint exactly from where we are sampling. If there is any lesion, we can actually target it to avoid the lesion areas, avoid the blood vessels, avoid the portal vein, the veins and all. So it's very scientific and very targeted approach, and it's more authentic and more accurate. And it can be done when there is a fluid, and you can roll around and you can maneuver. There are a lot of different applications that you can go in technicalities, and they are more accurate, I'd say so.
We can always have a debate on which technology is better or which has more proven results, but I have one small thought for the day with the audience. How ethical is it for doctors to prescribe certain models of equipment? A Fibroscan is not a test. So how ethical is it? Liver elastography is what we're looking at. Elasticity is what we are looking at. All right, now, Dr. Alka, you have done a lot of work with the head and neck ultrasounds. You're doing a lot of work with the thyroid especially. What is the ultrasound technology that you feel is really coming up, whether in terms of AI, whether in terms of color Doppler, whether in terms of high frequency transducers? What exactly do you feel are we looking at?
Definitely. Thank you so much for this question. This is one of my favorites. Way back when I was doing residency, we did thyroid ultrasound using a water balloon and using a standard C24 curvilinear transducer. From that, we have evolved to very high frequency transducers which give excellent resolution of the superficial structures, and we can get great detail of the nodules, tiny calcifications, their borders, their lobulations, their spiculations, everything can be really appreciated very well. And to top of that, the icing, we have little small footprint size, little hockey stick transducers that he can really maneuver around the clavicles, along the trachea and every other area. And of course, phenomenal Doppler sensitivity and color sensitivity contributes. Application of other tools such as elastography and modern other tools. Contrast is a research base, but the most dramatic results have come because of the smallest footprint transducers and a great resolution capability that has really gives phenomenal results, and you just need to have a passion of it. You can really, like, as if I'm just opening it up and I'm taking my lens and I'm using my binoculars and I can see everything. It's really amazing.
I think the take-home point here would be that, especially with imaging, that is ultrasound and MR, it is very important to have the right equipment. The right transducers which we are using, the application should be it's not one size fits all. So we cannot have a transducer which we can do a scan a lower limb veins with, and we cannot do with the same transducer with the thyroid. Anything else besides the frequencies that you would like to add in terms of, has artificial intelligence, would you like to elaborate on that?
Yeah, artificial intelligence is coming up. Computers trying to support us with various applications to do the thyroid scoring. When we are applying that, and it does give a calculation, but again, we need to know the limitations where we can apply it. So if you apply it in a calcification area, you will definitely get hard, right, results. So you have to remember the pitfalls. So that's why subjective assessment combined with artificial intelligence is the best thing. You can use that as a cue. However, our own interpretation of limitations, exclusions, inclusions is again a very paramount factor in deciding the scoring.
All right. There was a very nice question by one of the residents from AIMS, right? His question was that there was a panel discussion on artificial intelligence purely in DR and CR. Is Dr. Amit around, or has he left? His question was very specific. His question was that why should a hospital, since you're hospital based, why should a hospital buy the AI software from a vendor and also retain the radiologists? I'm just modifying the question slightly, but ultimately that is what it comes down to. So the panelists felt that AI will not replace the radiologists. Dr. Amit was of the opinion that if they are doing 200 X-rays, they will start doing 300 X-rays after AI comes in. How did that formula come? And what do you feel? Do you feel that AI in ultrasound would replace the radiologist?
The final answer is to replace. The answer is a no. But of course, technology is we are all in the process of evolution. So we came back that far. So we don't know 5 years, 10 years down the road, like how machines would be reading us and scanning us. So, I mean, there is definitely a lot of potential with AI. And it will probably smoothen and probably reduce the human labor. So way back we used to do cleaning, mopping and vacuuming. Now we have robots to do everything.
Right.
So we've got great hopes from technology.
Right. And do you feel that sonographers would be able to get those images which could be interpreted at a tertiary center by you?
Yes, definitely.
You know what I mean?
Yes, definitely.
If you have a peripheral center or a PHC, a primary health center, where they could scan a
In fact, I kind of see that happening maybe 5-10 years down the road. So because
that
the
is
equipment is there, digital image transmission, of course, we have got excellent
so
instant image
probably let us
transmission.
put it this way, maybe the sort of work would change.
Yes, it
The
will.
type of work would change,
Definitely.
Maybe we would be taking more of second and third referrals rather than doing the primary scans.
I think so.
Right. Dr. Aneja, don't feel left out. We were talking of fetal imaging with you all this while, and we briefly touched upon the topic of first trimester screening, where you were very emphatic about the Dopplers that
Correct.
are being
Yeah.
used. And could you just elaborate on that a little bit? Because I think that is very important, where we catch an early fetal growth restriction.
Thanks indeed for the question. I really want to spread this word on behalf of Samrakshan about the first trimester screening for preeclampsia and FGR. This is an absolute must. I don't know how many radiologists we have in the audience, but it's an urge to all radiologists to please do the first trimester screening for preeclampsia and FGR for every woman walking your door. And it is such a simple protocol. Firstly, we take the history which also includes the demographics. And the second step is mean arterial pressure, which has a definite technique to it. The blood pressure of both arms taken together, 2 readings, 1 minute apart. The third step is technology, which is uterine artery PI on the right and the left side. And the fourth step is putting all these 3 steps together in FMF calculator. And the calculator will give you the risk as well as the information as to what to do next. So if the risk, Samrakshan is taking cutoff as 1 in 150. So FMF takes it as 1 in 100 because the incidence of preeclampsia is very low in UK as compared to India. So we take it as 1 in 150. So if the risk is more than that, just start the patient. You can talk to the gynecologist and advise tablet Ecosprin 150 milligram to be taken at bedtime till 36 weeks or delivery, whichever is earlier. And believe me, this triple screening has a detection rate of 80%, and aspirin has a protection of 80%. So for example, if we talk of figures, India, we have 30 million live births in a year. Out of that, the incidence of preeclampsia is 8 to 10%. So we'll have 24 lakh preeclampsias in a year in India. So if all of us are doing preeclampsia screening in the first trimester, we detect 80% of these women. That means 20 lakh women in a year. And starting aspirin on them, we protect 80% of them. That is 16 lakh women and an equal number of babies they are carrying. So 32 lakh lives in a year we can influence if we all come together and do first trimester screening for FGR and for preeclampsia. It's such a simple technique. As radiologists, we just have to do the uterine artery PI. I think most of us are already doing it. Rest of the job is done by the staff. You just have to train your staff to take the history, to take the mean arterial pressure, and feed the information, the 3 protocols in the FMF calculator, and you get the risk there. So my staff does it for me. I do it for each and every patient in my clinic. And Samrakshan has come up with 2 years data. We have just published it in IJRI. And the results are dramatic. The study is done in 16 states and 38 districts. And Samrakshan protocol is followed for the first trimester screening and third trimester Dopplers for management of FGR. And the results are FGR and preeclampsia and neonatal mortality reduced to 1/3, maternal mortality and perinatal mortality reduced to half. So those are the results. I think we should all rise to this issue, the menace that our country is facing, and it is in our hands. We have technology in our hands. Why not use it? It doesn't take time. Just taking uterine artery PI and the rest of the job is done. And if you can fill the forms on Samrakshan website, which is a request by Samrakshan, because we currently are following FMF protocol. Ironically, India has 24 lakh preeclampsias in a year, and UK has 0.16 lakh preeclampsia in a year. And we are following their protocol because we don't have our figures, we don't have our data.
I think that's a point well taken. That is something which we need to learn. We are all doing great work, but somehow we are unable to gather the data, tabulate it, and hand it over to the right people
So
who are
if you
doing
just
it.
fill the forms on IRIA Samrakshan website, so the same thing what we are doing in FMF, the staff will
We
fill
just
the
put it
same
there and
form
that
there
data can be-
and just submit the form and the data goes there and they are doing the research and they are coming up with our own protocols, our own
Right.
cutoffs, our own values,
Right.
and I think that is what is the
So,
need of the hour.
as far as the current technology or the future technologies in ultrasound is concerned, I think we have covered right from Doppler to artificial intelligence to elastographies. Anything else that the audience would like us to cover? Any other topic? Or anything else that you feel is coming up?
So what I was wanting to say, the use of technology over a period of time we are using for diagnosis and management. So we have to take it to the next level up, that we screen wellness. Like that's the motto, that's the goal. So we are not doing diagnosis and management and chasing the things. Rather we go into the prevention mode. So like what she said, that's an excellent thing. It's like we learned MBBS, we learned from all the authors, we learned all the previous research, through all the previous researches. So it's just a small step ahead, contributing to our own researches and our own data, which will go a long way in transforming healthcare. So it's just a step up in that direction. That's my appeal to everyone. Thank you.
Wonderful. So we go more into preventive medicine rather than just in the curing part. Right? So shall we call it a day or anything else needs to be discussed? Thank you very much, Dr. Aneja. Thank you, Dr. Sarkar. Thanks, Alka. Wonderful being here. Thank you.
Thank you, thanks.
Just allow me a moment. We just need to present you a small token of, from our end. So just 1 minute.
Questions, most welcome. Thank you.
Yeah, please go ahead.
Can we have the mic, please? Samir, can we get the mic?
Hi, so I'm a junior resident in the All India Institute. I'm Dr. Shubhankar Datta. So basically, I'm aware of the work which Samrakshan has done and the work being done by Dr. Rijo. So in preventive medicine, it is not really talked about a lot in our residency. Like I have a personal interest, so I know about it, but not hardly 1% of the residents who are in training, they actually know about it. And even in the IRIA talks which are happening on a weekly basis or a monthly basis, it's hardly talked about. I think the only one which I have heard is in Kochi this week, the preventive medicine IRIA talk. But how do you plan on spreading this
So,
to the masses?
Samrakshan came up in 2019 and it has come a long way. Actually, it has gained momentum very lately, 2021-22. And if you go to the IRIA website, just you can Google search IRIA Samrakshan. And there you have Samrakshan pages. So they will tell you what is Samrakshan, what is the focus, how to go about it, how to do the screening, and they have videos to train you how to take the mean arterial pressure, the correct technique, how to take the uterine artery, and how to even we have uploaded videos as to how to train your staff. So currently we have 2-3 videos we have uploaded about training the staff. So you just play the videos, your staff will learn. This is a very easy thing for computer savvy staff to learn. It is nothing difficult. So you will find everything there. I mean, all that I have talked about, including the figures, the mortality rates and everything, and what Samrakshan has achieved so far. You have all the videos, all learning videos there. They're not
Yeah.
aware. So we are actually, we are spreading the word whatever way we can through social media, through medical colleges, and through the conferences. We are doing that. I think it's just a matter of time.
I think Samrakshan is like one area for fetal medicine. Like, for example, ultrasound, that's the way I really love ultrasound, because it's a tool that you have in your hand for early diagnosis. I mean, radiology stresses more on staging, and you know, that's like this thing. But what about the very early subtle signs when you've just normal versus abnormal? When you pick it up there, that's your achievement, that's your detection, right? Staging is like you're chasing the thing. So in every area, it can be liver, chronic liver disease with elastography, or even with just subjective assessment, even with kidney disease, even subjective assessment. For any area, even if whether you're doing an anomaly scan, whether it's an early scan or any level, so very subtle signs that you begin to, when you pick up, that's when we will be getting to the preventive role of, the role of preventive radiologist will come into play. It applies to each and every system, every area that you're looking at, whether it's ultrasound, CT or MR. The very subtle signs. Of course, complete clinical information, and that will transform things.
Right, and coming to elastography, like a lot of our radiology practice, even outside, is based on referrals by the clinicians. So as Dr. Rahul was mentioning, that the competition with Fibroscan, a lot of papers which have compared both shear wave, strain, as well as the transient elastography which Fibroscan uses, and many have shown that shear wave is better. We have shown they are comparable, but still the gastroenterologists, who are the first persons to see the patient, they are the ones to write down, advise Fibroscan. So unless we as radiologists start our own OPs and like move to kind of like clinical radiology.
We start our own OPDs.
Yeah, like what IR people do. They have their own OPDs in Calicut, intervention radiology OPDs. So how do we reach that area when we can ourselves prescribe elastography to a patient and can tell them, do this, you are a high risk for fatty liver?
See, look, Chief, I have been in practice for 30 years now, prior practice. What I will talk to you will be very, very practical. Like Dr. Amit told you, that if we buy the AI software, our access will increase from 200 to 300. How? So it's easier said than done. We will never have our own OPDs.
Right.
Okay, so just get that out. The reason is very simple, because all over the world, there is a complete flux. I have been to at least 10 RSNAs. There is a complete flux. We want to cater to the physician or surgeon, and we talk of subspecialization in the system. You're from AIMS. Do you subspecialize in systems? That is what you claim. But you keep on doing CT, MRs, and still on that same rotation.
Right.
So what is happening is, I've discussed this issue with maybe tens of people. What happens is that you have an OT in a hospital. Would the owner of the OT of the hospital allow you to do only neuro work out there, unless and until that quantum of work is there? So practically, you as a radiologist, if you come out with a fellowship of abdominal radiology and you go for an employment, nobody's going to hire you. Okay, because they want somebody who can take care of everything. Medanta started with that practice. When they started with it, they started with this practice. Ultimately, they had 50 ultrasound machines out there and nobody knew what to do with them, because nobody was responsible for them, because there was no ultrasound department. It's a very practical example. Maybe this was way before even she joined. Right in the initial days when Dr. Bajal had come in. Secondly, the main problem that is coming up is that we are not giving complete results. Fibroscan is giving you the KPA value and Fibroscan is giving you the cap value. Okay? Now what we are doing is we are giving the KPA value, but we are not giving the attenuation parameter. We are not giving the cap value. And they want a quantification for the liver fat. We started doing that quantification with liver fat with MR. When we started with our T2 star imaging, when we started with our fat fraction, and we were very successful with that. It's a very simple software, you run one sequence, you get the fat fraction. But somehow that just tended to be more expensive and that did not work out. But now, for the last 3 years, there are commercially available machines which are allowing you to do fat attenuation. So which is giving you the cap score in that same decibel, the way in which the Fibroscan gives. So we have to take the initiative to adopt the newer technologies and keep abreast. Right? We cannot afford not to adopt it. So we have to, the trade has already given us an opportunity. Those machines are lying there for the last 3 years, but we are not buying them.
Okay.
We have to adopt them. We have to start giving the reports which include the cap value as well as the KPA value. I hope I've answered that.
Yeah.
Thank you. Thank you so much. May I now request Dr. Ravi Gupta to kindly come on stage and present our panelists a small token of appreciation from the organizers. Can we have the mementos on stage, please? So we'd like to acknowledge the presence of Dr. Rahul Sachdev, Director, R Diagnostics, for being here today and for being a wonderful moderator. Thank you so much, Dr. Sachdev, for being here with us this evening. Can we have a round of applause, please? Dr. Kavita Aneja, Director and Senior Consultant, Images Ultrasound Centre. Thank you so much, ma'am, for being here. Dr. Alka A Singhal, Associate Director, Radiology, Medanta Medicity. Thank you so much, ma'am, for being here. And Dr. Tandra Sarkar, Senior Consultant Radiologist, Apollo Multispeciality Hospital. Thank you so much, ma'am, for being here.